denk dat je niet zo vreselijk veel macht hebt om dingen anders te laten gaan. Het gebeurt gewoon.
Maar ja, ik ben wel blij dat ik gewoon nog leef natuurlijk.
On voit l'être aimé complètement distordu et il est là, il est plus là, mais en même temps il est là.
Quando hai alle spalle un dolore, una sofferenza del genere, apprezzi anche le piccole cose. Non è scontato niente, non è scontato che respiri, non è scontato che stai in piedi e cammini, puoi correre, non è scontato vedere il sole, non è scontato niente.
Bijna verdwaasd rond, in een trance rond. Maar ik moet zeggen, de zorg eromheen is wel heel erg goed. En ja, het was een heftige tijd, maar wel een mooie tijd.
Welke gevoelens ik heb ervaren. Ja, je bent ontzettend nauw betrokken bij mijn vrouw, wat die meemaakt. En je kunt daar niks mee, maar je moet er zelf mee uit de voeten. En je hebt wel het volle vertrouwen, dat had ik wel steeds.
Io sono un medico di terapia intensiva, non un rianimatore, nel senso che lavoro con i neonati, quindi mi occupo di tutt'altra, di bambini molto molto piccoli, non faccio il loro stesso lavoro, però chiaramente il rapporto con i medici è stato condizionato anche dalla mia posizione, tra l'altro sono dei colleghi perché sono nel mio stesso, quindi da una parte ero sicuramente facilitata nel comprendere razionalmente quello che stava succedendo, cioè non avevo bisogno dei lunghissimi colloqui perché mi spiegassero per avere notizie cliniche, perché era più semplice riassumermi le cose. D'altra parte, dal punto di vista umano, dal punto di vista emotivo, questo non è servito a niente, anzi forse ha peggiorato le cose, perché sapevo cosa poteva sucedere e non volevo accettarlo.
Ahora lo que me motiva es mejorar la vida de la gente. Ya no es tanto la técnica, ¿no?, como cuando eres joven, porque llega un punto que la técnica es técnica y no tiene ningún secreto, sino las pequeñas cosas que pueden hacer que marcan la diferencia. El hablar con el paciente, con la familia, el hacer una educación sanitaria que nadie ha hecho hasta ese punto y tú no lo sabías porque dabas por hecho que lo habían hecho. Esas cosas son las que te motivan, el mejorar el cuidado del paciente.
Il faut faire du cas par cas, en fait. C'est primordial, parce que chaque histoire est différente. Et quand vous vous trouvez en tant que patient, en tant que famille de patients, dans cette situation, dans un univers où vous ne parlez pas cette langue-là, cette langue faite d'acronymes et de termes techniques que vous ne connaissez pas, quand vous vous retrouvez face au savoir et que du coup vous vous retrouvez impuissant, que vous vous retrouvez stupide, que vous vous retrouvez humilié, que vous vous retrouvez démuni, comment faire?
Jokainen lääkäri varmaan pelkää komplikaatiota tai jotakin, että mitään ei hiffaa jotain juttua, mitä olisi pitänyt hiffata, joskin siinäkin auttaa se, että harvoin tekee yksin koko päivää töitä. Nämä tuli nyt äkkiseltään mulle mieleen.
And what scares me is that making those decisions and making those wrong decisions and the realization that that decision in 3-4 weeks' time, where you end up having a patient who, in effect, can be crippled by life-sustaining therapy, which may not have been in their best interests or the family's best interests. And that still scares me. And I think it scares a lot of colleagues, but intensive care is much more multidisciplinary now, and I think that has helped our decision-making and has reduced that fear factor.
Honesty and humility go a long way. And most patients and relatives understand that we're also human and mistakes can happen and should be openly discussed.
Οι ασθενείς όμως έρχονται σε επαφή με εμάς, ιδιαίτερα αυτοί που βγαίνουν από το νοσοκομείο, πηγαίνουν σε κέντρα αποκατάστασης και ύστερα από πάρα πολύ καιρό έρχονται να μας συναντήσουν, γιατί ξέρουν τα πρόσωπά μας, τις φωνές μας, τον αγώνα που δίνουμε μέσα στο χώρο για να καταφέρουμε να τους σώσουμε, να επιβιώσουν και έρχονται να μας δουν, να μας γνωρίσουν από κοντά, να τους δούμε κι εμείς.
Together with my colleagues, in particular the nursing colleagues, we arranged a wedding for a patient who was at the end of his life and had decided to marry his long-term partner before he later died. And it was very moving to be part of this very special event in the intensive care unit.
It's a real privilege to be able to support a patient and their family through that, what I hope is the worst thing that ever happens to them in their lives, to be able to support them through that, hopefully to recovery, or to support them through managing a dignified death.
Il faut ramener la vie. Pourquoi est-ce que tout est si blanc et voire gris? Pourquoi est-ce que ce lino couine autant sous les crocs des médecins? C'est insoutenable. Pourquoi est-ce que tout est autant aseptisé? C'est pas 3 photos qui vont empêcher les gens de travailler. Moi, je pense que c'est important de ramener de la vie à cet endroit où on se trouve à la frontière au bord d'eux, on se trouve dans une espèce de no man's land où on sait pas sur quoi ça va déboucher, quoi.
La mia opinione della terapia intensiva è fantastica perché mi hanno salvato la vita e dopo 3 anni sono qui. Anche a un altro ospedale che mi hanno dato per morto, per fortuna sono arrivato in questa terapia intensiva e mi hanno salvato veramente la vita.
Solo belle cose possono uscire dalla mia bocca, ovviamente, perché senza di loro non sarei qui, ripeto, non sarei qui oggi.
Intensive care medicine allows me to learn something new every day. So every day I meet colleagues and I hear of their new technologies, new advances, and progress in their particular specialty. But most importantly, every day is a different day with new challenges, and I enjoy the interaction with my colleagues and most importantly with patients and their relatives. So it provides a great variety, it's different every day, and it's a specialty where progress is made on a regular basis.
Grazie perché mi hanno ricordato anche come si lavora. Cioè, io faccio questo mestiere, lo faccio da tanti anni, ci sono dei momenti in cui sei stanco, in cui hai le tue cose, nel senso che hai la tua vita, hai delle preoccupazioni, però io ero serena quando andavo via, non perché sapevo che non sarebbe morto, poteva morire, poteva star male, ma era nelle mani migliori, sapevo che era nelle migliori mani e questo mi dava quel minimo di tranquillità che potevo cercare. È giusto che i bambini che mi vengono affidati e i genitori quando vanno a casa possano pensare la stessa cosa. Siamo nelle migliori mani, quindi dobbiamo sempre fare il meglio. Grazie a loro per esserlo il meglio.
So I am a full-time intensivist and proud to be one. We're all working together in a multidisciplinary fashion to fight COVID-19. Together, we are intensive care medicine.
Hello, I'm internal medicine specialist and I'm proud to be an intensivist. We intensivists are working hard to fight for COVID-19. Together, we are intensive care medicine. Thank you.
I am the editor of Intensive Care Medicine Journal and I'm proud to be an intensivist. We are working together to fight COVID-19 and to take care also of non-COVID patients. Together, we are intensive care medicine.
I'm a nephrologist and I'm proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
I'm an anesthesiologist and I'm proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
Good afternoon and welcome
Good
to
afternoon,
this
everyone.
ACICM webinar on Flow Nasal Oxygen for COVID-19 and beyond. And thank you to Massimo for supporting this webinar. I'm Salvatore Maggiore, Professor in Anesthesiology and Critical Care Medicine and Chair of the Department of Anesthesiology and Critical Care at the Hospital of Chieti, Italy. And it's my pleasure to co-chair this session with Professor Roseo from Foggia, Italy. Michela.
Thank you. Thank you, Professor. Thank you. Nice to meet you, and thank you for joining us in this afternoon for this live where we're going to talk and explain between us all the aspects related to the use of high flow nasal oxygen in COVID and beyond. So thank you for joining us.
Okay, so this webinar will be very charged of many informations from different perspectives, and I suggest not to lose further time to go directly in the topics. So, Michela.
Yes. It's
Maybe
with great honor.
Present me.
Yeah, it's with my great honor to introduce you one of the pioneers in terms of non-invasive ventilation and use of H-flow nasal oxygen. So Professor Maggiore is going to give us a beautiful view from his point of view about non-invasive respiratory support in COVID-19 patients. Please, Professor.
Thank you, Michela, for the nice words. So in the next few minutes, I will talk about the use of non-invasive respiratory support in COVID-19 patients. These are my conflicts of interest. I received lecture free from Dragon Medical and GE Healthcare. So when we talk about COVID-19 patients, we're talking with patients about patients who present to the hospital very often with interstitial pneumonia, with this ground glass opacity, and sometimes associated with the area of lung collapse. From a clinical point of view, these patients present with severe hypoxemia, not associated with dyspnea and tachypnea. This is why it's been called silent hypoxemia, hypoxia, and with normal respiratory mechanics. And later on, this picture may evolve to severe refractory hypoxemia, eventually associated with dyspnea, tachypnea, use of accessory respiratory muscle, strong respiratory effort, and impairment of respiratory mechanics. Now, these patients, particularly at the beginning of the disease course, are often treated with non-invasive respiratory support. And we have several forms of non-invasive respiratory support technique to be used in these patients. And in this slide, I show you here the airway pressure tracing and the airflow tracing with different techniques as compared to spontaneous breathing with standard oxygen. For example, we have the nasal airflow technique where we set very high gas flow, and with this technique we can generate a modest level of PEEP. Then we have other form of non-invasive respiratory technique like CPAP, where we set one single level of pressure around which the patient breathes, or non-invasive ventilation with two levels of pressure, PEEP and pressure support, to further support the respiratory muscle. And this technique may be used with different interfaces, face mask or the helmet. Now, what we know about the use of these techniques in COVID-19 patients? Well, we have several guidelines which have been issued at global and European level. And as you can see, all the guidelines in some way support the use of all these techniques. In general, very weak or conditional recommendation. And however, most of this recommendation comes from the evidence collected in patients with hypoxemia before COVID-19 pandemic. So if we look at the current guidelines by the use of this technique, for example, concerning nasal airflow, we can see from meta-analysis performed on different studies on the use of nasal airflow in hypoxemic patients, not necessarily COVID-19 patients, that this technique does not improve mortality, but significantly is associated with significant reduction in the intubation rate. And based on this consideration, the recent guidelines about the use of nasal airflow in hypoxemic respiratory failure recommending using this technique as compared to standard oxygen for patients with hypoxemic respiratory failure. This was a strong recommendation. What about non-invasive ventilation? Where here the available results showing are more conflicting, and indeed meta-analysis shows no effect on non-invasive ventilation as compared to standard oxygen, both on mortality and on intubation rate. And for this reason, the actual guidelines do not offer any recommendation by the use of NAV in these patients. I think that we should consider a couple of issues to better understand what kind of support to apply and how to choose the right support and right patients. And one first issue is the severity of patients, for example, based on oxygenation, or the PO2-FiO2 ratio. For example, in this study, which was a secondary analysis of the lung safe study, which was a very large study about the ventilatory management of patients with ARDS, both with non-invasive and invasive mechanical ventilation. This analysis was focused in patients treated with non-invasive ventilation. And what these analyses show is that while in the less severe patients, those with a PO2-FiO2 ratio greater than 150, there was no difference in outcome, in this case survival, between non-invasive ventilation and invasive mechanical ventilation. In the more severe patients, survival was lower with NAV. Essentially the same was showed also with nasal airflow. For example, these were a very small retrospective study performing COVID-19 patients in China. And again, also for this technique, you can see that the failure rate was different based on baseline PO2-FiO2 ratio, with a very high failure rate, greater than 60% in the less severe, and essentially no failure rate in the less severe. So one thing that we can see is that we can say from this data is that both NAV and nasal flow may be safely applied in the less severe patients, those, let's say, with a PO2-FO2 ratio greater than 150, but we must be much more cautious in the most severe patients. Another issue concerning specifically non-invasive ventilation concerns the interface that we use for apply this technique. And for example, we know from this study by Patel and co-workers that the use of helmet non-invasive ventilation as compared with the face mask non-invasive ventilation in patients with severe RDS was associated with a decrease in intubation rate and an improvement in survival. So there is a difference between interface. And from a technical standpoint, the most striking difference between these two interfaces, the NAV technique with these two interfaces, was the level of applied PEEP, which was significantly higher with the helmet, while with the face mask was not possible to set very high PEEP because of patients' intolerance and excessive air leak. Now, applying high PEEP with helmet, which is also in general more comfortable for patients. So this allows to apply this high level of PEEP for a longer period of time as compared to face mask. Applying this high level of PEEP it may have beneficial effects, not only in terms of improvement in oxygenation, but also in decreasing the additional lung injury that can be produced by the strong patient's effort, leading to the so-called patient self-inflicted lung injury. In this study, for example, the researchers compare the effect of spontaneous breathing with high level of PEEP or with low level of PEEP, so during non-invasive ventilation, both in animals and in patients. So what they found that when spontaneous breathing was associated with high level of PEEP, the level of the inspiratory effort was lower as compared to low PEEP. So stronger effort with low PEEP as compared to high PEEP. And this was true in animals and in patients, and was associated also with a decrease in the inflammation observed in the caudal and dorsal zone with low PEEP, and this you can see with high PEEP was prevented. So the beneficial effect of high PEEP may be in terms of improvement of oxygenation, but also rendering the spontaneous effort less injurious. And very recently, this network meta-analysis suggested that, in general, non-invasive form of respiratory support may be beneficial in hypoxemic respiratory failure. Of course, with difference between the different techniques, probably an advantage of helmet and NAV as compared to face mask NIV and nasal flow. But in particular, in this meta-analysis, what was clear is that there was no direct comparison between helmet non-invasive ventilation and nasal flow oxygen. Based on these data, together with Domenico Grieco, which is the principal investigator of these studies and also other studies, and Massimo Antonelli from Rome, we designed a first physiological study to compare nasal flow and helmet non-invasive ventilation in 50 patients with severe hypoxemic respiratory failure and 130 of PO2-FO2 ratio, and these were applied for 2 short periods of 60 minutes, applied in random order. And the main endpoint was oxygenation in terms of PO2-FO2 ratio. As you can see, with helmet non-invasive ventilation, oxygenation was better, but also this was associated with a decrease in the expiratory effort, respiratory rate, and dyspnea, more evident with helmet NAV as compared with nasal flow. Interestingly, what we found is that the decrease in the inspiratory effort obtained with the helmet non-invasive ventilation as compared with the nasal flow was stronger strongly associated, it was strongly dependent by the intensity of the inspiratory effort with nasal flow. So if the patients showed a very strong effort, applying the helmet was able to significantly reduce this effort, and this was associated also with a decrease in transpulmonary pressure. While if the patients with nasal flow have very low inspiratory effort, so no effort, no real patients less severe, there was less effects, beneficial effects in reducing the inspiratory effort with helmet, even an increase in transpulmonary pressure. So the conclusion of the study was that helmet NAV may be probably more effective in nasal flow, but especially in patients with more severe oxygenation impairment and more vigorous inspiratory effort. Based on the results of this physiological study, we designed a multicenter randomized controlled trial, the ANNIVAL trial, which has been published always with Domenico, first author, and Massimo Antonelli from Rome, which was published a few days ago in JAMA. And this study compared again in patients, in hypoxemic patients with moderate to severe hypoxemic patients in 4 ICU. In Italy, we compare helmet NAV and nasal flow, and the included patients were very severe with an average PO2-FO2 ratio of 100 and respiratory rate of 28. And nasal flow was set at the maximum gas flow allowed by the equipment we use, 60 liters per minute. The primary outcome of this study was the median number of days free of respiratory support within 28 days after enrollment. And with this, we meant days free of any form of respiratory support, both non-invasive support and invasive support. Concerning the helmet, this is the setting we use with quite high level of PEEP, 10 to 12, the same pressure with pressure support. So helmet was used with a ventilator, able to deliver pressure support ventilation with 2 levels of pressure, a very fast pressurization time, very sensitive inspiratory trigger, and this was the setting. And concerning the primary outcome, there was no difference in terms of respiratory support free days between the two techniques. However, among the secondary pre-specified secondary outcome, we look also at the need for intubation. We found a significant reduction in intubation rate from 50 to 30% with helmet non-invasive ventilation as compared to nasal flow. And the cause of intubation was also significantly different, with less patients undergoing intubation with helmet because of hypoxemia, respiratory muscle fatigue, and worsening of dyspnea. And also another pre-specified outcome was the invasive ventilation free days, which was significantly higher with helmet non-invasive ventilation as compared to nasal high flow. Of course, one important thing could be to identify a subgroup of patients who may benefit the most from helmet non-invasive ventilation. So we look at this index, this score, the oxygenation to dyspnea score, which is the PO2-FO2 ratio divided dyspnea, with the most severe patients having a lower score, highest score identifying less severe patients. And we divided the population of the ANNIVAL trial in the less severe, with a score greater than 30, or more severe when the score was below 30. And what we found is that in the less severe patients, according to the score, there was no difference in the intubation rate between these two techniques. However, in the most severe, we found the greatest benefit of helmet non-invasive ventilation, reducing the intubation rate, which was in this case significantly lower. So in conclusion, I would say that both nasal and flow and IPEEP helmet and non-invasive ventilation are probably the technique of choice for the non-invasive respiratory support in hypoxemic patients. Probably the helmet non-invasive ventilation may be more beneficial in the most severe patients, because in these patients may, especially in these patients, may reduce the intubation rate. But in any case, with any form of respiratory support, I would like to say that it is extremely important, a careful monitoring, not to delay intubation and the institution of protective ventilation. And I thank you very much for your attention. Okay, so after that, I don't know if Michela want to present also the second speaker, and then we have a question and answer discussion at the end of the three presentation. Otherwise, I will do. It is my pleasure to introduce Jens Brownlick for the second presentation. And Jens will talk about flow in COPD patients, acute hypoxemic respiratory failure. Jens comes from the ICU of the University Hospital in Leipzig in Germany. Jens?
Yes, yes. Okay. Thank you very much for this kind introduction. My name is Jens Brownlick from Germany. I want to speak or highlight some aspects of the benefits of nasal high flow in COPD patients and acute hypoxemic respiratory failure. These are my conflict of interest in this presentation. The research of nasal high flow, especially for acute hypoxemic respiratory failure, goes about, I think, 10 years ago. One of the first papers about this topic came from Spain, from Oyo Roca in 2010. And he compared in this first study face mask with oxygen and the nasal high flow in acute respiratory failure on only a low count of patients. And these were patients with a high respiratory rate of 28, this was the baseline, and in hypoxemia. And they found in his study that nasal high flow is better if it can reduce the respiratory rate in these patients compared to oxygen face mask, and has also an impact to the oxygenation measured in PaO2 in this study from 227 to 77 millimeter mercury. This was the first study which have shown the impact of nasal high flow in acute hypoxemic respiratory failure. And a little bit later, 5 years later, Jean-Pierre Fratt, you all know this study very good, investigated 300 patients with acute hypoxemic respiratory failure and with, in the mainly part of them, with pneumonia, and they randomized these patients to a nasal high flow group, to a standard oxygen group, and non-invasive ventilation group. When you see in this slide, this was very severe oxygenation impairments in these patients, and with a very high, I have not shown here, respiratory rate. And the primary outcome of the study was the incidence of intubation. In the whole group of these 300 patients, they found no difference between non-invasive ventilation, the standard oxygen, and the nasal high flow. But in the subgroup with a higher impairment of oxygenation below 200 millimeter Hg, they found the benefit of nasal high flow in terms of intubation compared to non-invasive ventilation and standard oxygen. And as a secondary outcome, they investigated the probability of survival, and they found that nasal high flow is able to improve the survival in these very severe and sick patients. And as you have seen in the presentation by Salvatore MAGGIORE, you can also see here nasal high flow is able to prevent invasive mechanical ventilation in a number needed to treat from 28 compared to oxygen. And I think it is very clear that nasal high flow is able to prevent intubation after we have seen all the studies in the last year. And this meta-analysis was published 2020, and I show you something about the results of the study without the helmet, non-invasive ventilation. This was shown by Professor Maggiore. Here you can see non-invasive ventilation with the nasal high flow with in the comparison of all-cause mortality and intubation rate. And you can see nasal high flow is not able to reduce the mortality compared to non-invasive ventilation, but both oxygenation strategies or support strategies can reduce the need for intubation, as we have shown in this slide before. But very interesting in this work is the fact, if you look at the sensitivity analysis, especially for the all-cause mortality in these patients, you found if you exclude patients with COPD, no benefits on mortality in terms of you use non-invasive ventilation. And in this case, if you exclude especially these patients, you have no difference in mortality between nasal high flow and non-invasive ventilation. So the effect in acute hypoxemic respiratory failure could be the same in our patients. And as also shown in the presentation before, nasal high flow is the strong recommended therapy in hypoxemic acute respiratory failure today. But in my own research over the last year, it was interesting for me to understand why nasal high flow is able to support ventilation or to bettering oxygenation. And one idea why nasal high flow is able to do this is that nasal high flow have a small increase in airway pressure. There is an alveolar recruitment, homogenization of the alveolar ventilation, and therefore an improvement in oxygenation. But I think this is not the all true in all cases. If you show on the left side, you see compared non-invasive ventilation to nasal high flow with different flows, that nasal high flow, if you measure the mean airway pressure, is very lower than in non-invasive ventilation. And if you open the mouth, nasal high flow is also not able to get such a high pressure like in closed system like non-invasive ventilation. But the nasal high flow is able to increase the end expiratory lung volume and have a small PEEP effect in these patients, but not the same like in closed system. And if you compare non-invasive ventilation in your mind with nasal high flow, you have very different pressure cycles. Especially if you use non-invasive ventilation, you can increase the pressure in the inspiratory cycle, and you have a small PEEP or a higher PEEP in the expiratory cycle. This is not the same if you use a nasal high flow device. If you inspire your air in the inspiration cycle, your pressure is very low. In the expiration, you have a higher pressure, so a small PEEP, because you breathe against the flow of the nasal high flow device. And this is a very important difference, in my opinion. That means if you need a higher airway pressure in your patient, for instance, with a sleep apnea or something else, you should use a closed system like non-invasive ventilation, and perhaps not nasal high flow device, but this is only a part of our patients. There is also another idea why nasal high flow is able to bettering the oxygenation in our patients. If you think on your patients with a high respiratory rate, with acute hypoxemic respiratory failure, these patients include a lot of air with a lot of flow in their nose or in their mouth. And the flow can be up to 150 liters per minute. And if you use a low flow oxygen device in your nose, you have an inclusion of non-oxygenated air from the room air. And if you have a higher flow and high respiratory rate, you have a lot of non-oxygenated air, and your FeO2 in your airways is lower. If you use a nasal high flow device, you include in these patients 40, 50, or 60 liters per minute with oxygenated air, and the additional room air who comes in is much lower. Therefore, you have a better oxygenation during use of a nasal high flow device because of the lesser admixture of non-oxygenated room air. And I think this is a very important mechanism. And you can see this also in this study I have shown you the clinical data from Oriol Rocker. I've shown you before in this in vivo study from Vaxta from 2007. If you have a higher respiratory rate, and you compare this with an oxygenation device with a low flow oxygen, your device, your nasal high flow device, is able to stabilize the oxygenation in higher respiratory rate, and that's why the oxygenation additional to the increase in end expiratory lung rim might be better. When you can see, if you see all the studies who have good data for this fact, you see if you use a nasal high flow and measure the oxygenation in these patients, you have better outcomes and an improvement of nasal high flow if you use this in higher respiratory rates. There are some additional effects, especially interesting acute hypoxemic respiratory failure, but also interesting if you use the nasal high flow as a respiratory support device. Especially in COPD patients, it's the second part of my speech, you see you can increase the tidal volume in these patients. This means you have not only in recruitment, you have in these patients also, you have a very low tidal volume if they have an hypercapnia and have a decrease in muscle, in breathing muscle. You can increase the tidal volume in your patient because you can support these breathing in these patients. And also in consequence of this, the respiratory rate decreases in our patient. The calculated minute volume is the same if you use a nasal high flow device, and you can support very good the respiratory stress in your COPD patients. And this might be also a benefit if a patient with COPD will have a higher dead space ventilation because of the muscle weakness in his disease. You can reduce the dead space ventilation if you include your high flow, your volume in the patients in every inspiratory cycle. Therefore, your alveolar ventilation might be better if you have no not to use a high power to overwhelming the dead space ventilation in our patients. And this is a beneficial effect who can support ventilation in our COPD patients. In all this leads to a reduced work of breathing. This is a very simple picture. There are a lot of very good papers in the past published. And you see here compared in COPD patients to oxygen that nasal high flow is able to decrease the work of breathing in COPD patients, but also in patients with acute hypoxemic respiratory failure. There is also a very important effect from the nasal high flow, the so-called washout effect of the airways. This washout is not limited on the upper airways. This is also in the lower airways I have seen in the past. And this is a very simple experiment. We have used the nasal prongs in our ears on both ears, on one ear, and also this with different flow rates. And if you increase the flow rate from 20 to 30 liters per minute, you can decrease the PCO2 measured in capillary arterial blood. And if you use the nasal high flow with a higher leak, it's the same like you can open the mouth. You have a better decrease in PCO2. And if you additional, and this means then D, then you can increase the flow and you have also an additional effect and the best effect of decrease of PCO2. And this is the function of the washout of the airways in your expired gas in your airways. And there is another very important effect of a nasal high flow device. If you introduce your warmed and humidified air in your airways, this is very good for the comfort for this patient, is good for the tolerance with such a higher flow like 50 or 60 minutes per minute. But on the other hand, you have also an effect on your movement of your cilia in your airways, and you have bettering in some inflammatory processes. This is a little bit older study from Kilgo, and you see on the left side, if you look at the movement of the cilia in your airways, if your temperature in the airways or humidification goes down from 37 to 30, you can see the movement of your cilia is not so good, and the clearing end of your airways is not so good if you use a cold and not humidification device or oxygen. And if you look at some data from COPD, our own group looked since 2012 in a study in patients with chronic hypercapnic COPD for the decrease of PCO2. This was our first way before we can use a nasal high flow device in acute hypercapnic COPD patients. We proved this in chronic hypercapnia. We randomized our patients to two allocations. The first allocation was to use the nasal high flow device for 6 weeks and then switch to non-invasive ventilation. And the other group started with non-invasive ventilation and switched to a nasal high flow device. And we recruited 102 patients, and the primary endpoint was the PCO2 change from baseline, and the secondary endpoints were lung function, quality of life, very important in treatment of patients with chronic hypercapnia with non-invasive ventilation. And we found in our study a very clear sign. Nasal high flow was not inferior in case of the primary endpoint, the reduction of PCO2. You see this in this waterfall plot, and the upper part is the nasal high flow, and the lower part is non-invasive ventilation. And we found also no difference in terms of quality of life, though we think nasal high flow is able to support patients with chronic hypercapnic COPD. And there is also another interesting study, also in stable patients, for your interest, from Denmark. This is not the moon landing, this is the plan for the randomization of this patient and allocation. They gave 100 patients nasal high flow device at home, and the other patients standard oxygen. This were partly hypoxemic patients and hypercapnic patients, and monitored these patients for an exacerbation. And the patients were at 6 months in the hospital, and on the other visits they had a telephone contact. And they found that the nasal high flow is able to reduce the exacerbations per year. And this was also true in the hypercapnic group. This was published in this year, this subgroup analysis. And therefore, I think nasal high flow is not only a good support of breathing in COPD patients, but it can also reduce the exacerbation rate, perhaps because of the humidification of the airways. And the first data on patients with acute hypercapnic COPD comes from our group. On the left side, you see the whole group of these patients with hypercapnia, and on the right side, you can see the acidotic patients. And especially on the right side, we used at the first line in this patient, there were no randomization, no control group. We used non-invasive ventilation. All these patients had an intolerance of non-invasive ventilation for many reasons. And after that, we used the nasal high flow device, and we have shown in this observational study that the pH was decreasing after 2 or 4 hours, and the PCO2 was decreasing in our group. And this, I think, was a good sign to make some more studies in this topic. And one very important topic study comes from Italy, published in 2020. There were randomized 80 patients with a hypercapnic acidotic acute exacerbation of COPD, and 40 patients went to the nasal high flow group, and the other patients were treated with non-invasive ventilation. And the PCO2 as the primary outcome parameter was measured 2 hours after randomization and use of the different devices. And they found in the intention to treat analysis no difference between nasal high flow and non-invasive ventilation. As a consequence, all over the world, there are some groups who look now for the use of nasal high flow in the strong recommended area of non-invasive ventilation, the acute acidotic hypercapnic exacerbation of COPD, and want to prove the theory that nasal high flow is able to support also our patients compared to non-invasive ventilation. And we have also today we get the go from the ethic committee to start our study, supported by the German government, to use nasal high flow compared to non-invasive ventilation for 27 hours. This is the primary endpoint. The switch of the devices is a combined endpoint, that and the use of an additional support or intubation. This will start today, and we want to include 700 patients in our analysis. I hope we will have some answers for this topic. And therefore, I want to thank you very much for your attention in this topic, and I give back to Professor Maggiore for the next speaker. Thank you.
Thank you very much, Jens, for this very comprehensive, very nice review on the topic. And now we should move on, and it's again my pleasure to introduce Professor Reuseo, who will talk about the use of nasal flow in the intubation phase, both for pre-intubation and peri-intubation, and in post-intubation phase. Michaela, it's up to you. Switch the mic.
Can you
switch the mic?
Can you hear me?
Yeah.
Okay. Thank you so much for the introduction, for the presentation, also for this beautiful talk. So, going deep on the mechanism, which is the most fascinating thing about high flow nasal oxygen. As you can see in this wonderful drawing by Edward Gallagher, published on the Blue Journal in 2017, there's a huge amount of mechanism that actually altogether can give an improved clinical outcome in the patient undergoing a trial of H-flow nasal oxygen. And as you can see, the mechanisms are so wide. That is the reason why the panel of experts published these guidelines related to the importance and the evidence base in terms of clinical application of the H-flow nasal cannula. And so in my talk, we will try to figure out what's the importance and if there's any clinical point of view for which we should or we should not apply high-flow nasal oxygen in the peri-intubation and in the post-extubation period. So what the panel made for what regard the peri-intubation period is almost clear with moderate certainty. And what they say is that, sorry. Oh, okay. Can you still see the presentation? Okay. And so what they say for the peri-intubation period with moderate certainty is not recommendation, and let's see why. So in this trial, as you can see, published in 2016 on respiratory care, a group of 40 patients has been analyzed, and the authors of this study, they compared the level of SpO2 in the peri-intubation period when comparing the application on high-flow nasal cannula to the back valve mask. And what they found was really interesting because, as you can see from the results, there was no actually difference between the two treatments. So that's what they showed, and also in terms of oxygenation. And so they say for hypoxemic respiratory failure, there's no difference if you apply H-flow nasal cannula or if you do pre-oxygenation with a back mask valve. So no change in terms of SpO2. So the lowest level of SpO2 reached in the pre-oxygenation period was exactly the same. Again, another wonderful job in this beautiful trial of the 313 patients analyzed, in which they compared non-invasive ventilation versus high-flow nasal cannula during the peri-intubation for the apnoic oxygenation in patients with acute hypoxemic failure. It's been said that for what regard the guidelines, the panel made an observation for this for the peri-intubation period of about 10 trials. 5 of them were on acute respiratory failure. The other 5 were in the OR, so during general anesthesia. For what they regard this job, what they found was that in the overall population, which is figure A, there was no difference in terms of SpO2. So the lowest level of SpO2 was exactly the same when going from non-invasive ventilation or Flow Nasal Cannula. But if you observe on figure B, in figure A was the overall population with acute respiratory failure and a PF ratio below 300 millimeters of mercury. While in figure B, they actually evaluated the behavior of the patient in terms of lowest SpO2 level for patient with acute respiratory failure and a PF ratio below 200. And so there was a little bit lower level in terms of SpO2 after in the peri-intubation period for what regards patients treated with Flow Nasal Oxygen. But in the overall population, there was actually no difference. Again, another study of 124 patients in which they compared the effect of Flow Nasal Cannula during endotracheal intubation when compared to face mask. And as you can see, for what regard the lowest level of SpO2 during the peri-intubation period, also in this study, also in this trial, there was no actually difference. So it was exactly the same, as you can see, for what regard the two groups in terms of statistical analysis. Again, another study, 184 patients in which they compared nasal high flow again with a bag valve mask in critically ill patients. And so also in this study, there was no statistically difference, and so the treatment was exactly the same, and there was no statistically difference in terms of lowest SpO2 between the two groups, so the high flow group and the standard bag valve mask group. And then, as you can see, it's exactly the same for what regard this kind of population. The last trial that I would like to point to with you to focus the attention on is this beautiful trial, the Optinib trial, with 49 patients analyzed, in which, as you can see, it's a beautiful study, in which because of the apneic oxygenation given from the use of Flow Nasal Cannula, the two groups of 49 patients, so 24 versus 25, were actually compared, but with a different trend. One group was the treatment together with Flow Nasal Cannula and NIV versus NIV alone. As you can see, there was actually statistical difference in terms of minimal SpO2 value, and so the group with NIV alone had a worse SpO2 value when compared to the group that actually used both NIV and Flow Nasal Cannula. And so that's why for the peri-intubation period, this is the idea given from the panel for the peri-intubation period. But let's see what was the suggestion made from the panel for what regard the post-extubation period. So the panel said, following extubation with moderate certainty, conditional recommendation. So it's a little bit different. Let's see, starting from this beautiful job from Professor Maggiore, published in 2014 on the Blue Journal, in which they actually compared the effects of Flow Nasal Cannula versus Venturi mask. Oxygen period for what regard the post-extubation period. And so what they found, as you can see, is that in terms of oxygenation, actually, given the period of observation of 72 hours, actually, after the 24th hour, there was actually a better oxygenation from patient going from patient with Flow Nasal Cannula, in opposite to conventional with Venturi mask oxygenation. And plus, there was a better saturation and also a better outcome in terms also of comfort and dyspnea in this kind of patient. Again, always talking about respiratory rate, comfort of the patient, and also hemodynamic parameters such as heart rate. This beautiful study of 17 patients by the group of Professor Rita Yamai, in which they actually evaluated the difference in terms of post-extubation going from high flow nasal cannula versus COT, conventional oxygen therapy. And they found a superiority in terms of comfort of the patient and respiratory rate, and a better heart rate for patient using H-flow nasal cannula in the post-extubation period. Still, JAMA 2016, this beautiful of 527 patients of the group, in which they evaluated the effect of post-extubation high-flow nasal cannula versus COT, so conventional oxygen therapy, but in low-risk patients. And what they found was that, as you can see, there was actually a difference, a statistical difference, which was in favor of high-flow nasal oxygen when compared to conventional oxygen in terms of percentage of intubation, and it was statistically significant. What it was another point that the same group highlighted a little bit later, so from April 2016 to October 2016, was the application of high-flow nasal cannula versus this time NIV, but instead of low-risk patient, this time was on high-risk patient. And so low-risk patient was COT versus high-flow. High-risk patient was NIV versus high-flow. And in the trial, what the authors showed was a non-inferiority result in terms of comparison between the two treatments. And so they differentiate the population, which is the same thing that is highlighted in the panel from the experts, when going from the two type of treatment, so either for non-invasive ventilation and high-flow nasal cannula. So non-inferiority or high flow, and also no difference when evaluating the mortality comparison between the two treatments. Again, another study which was on high flow nasal cannula to prevent post-extubation respiratory failure, again in high-risk patients. And so what they saw was there was actually, they couldn't find a success or either a not success, because the comparison between the two groups in 155 patients implied that there was no statistical significance between the two, and also from what regard all the other outcome variables, there was actually no difference at all. So given the data coming from the panel of experts, just to summarize, we can say that for the peri-intubation period, the panel of experts made no recommendation for the use of H-flow nasal cannula in the peri-intubation period. For patients who are already receiving H-flow nasal cannula, the panel suggests to continue H-flow nasal cannula during the intubation, but with moderate certainty, a conditional recommendation. While for what regards post-extubation respiratory failure, the recommendation from the expert says that H-flow as compared to COT following extubation, it depends also from how many hours the patient is extubated. So for patients undergoing an intubation of probably 24 hours is fine, but they wanted to point out the attention on the fact that respiratory failure and patients with respiratory failure are different based on, of course, from the PF at the baseline. And so if the patient are intubated for more than 24 hours and have a high-risk feature, is a conditional recommendation with moderate certainty evidence. But for patients that already the clinician would put on NIV-PPV, the panel suggests to continue to use NIV-PPV as opposed to H-flow nasal oxygen, but with a low certainty evidence and a conditional recommendation. Thank you so much for your attention.
Thank you. Thank you, Michela, for this really nice and exhaustive presentation. So I will now will discuss some questions were coming from SICM TV and from social media. And there are a few questions, for example, concerning, I think that there is one question which is important, very actual, concerning the pandemic. And the question is if just for sparing oxygen, NIV could be more interesting than nasal flow. The concern is the oxygen consumption with nasal flow as compared to NIV. And I could say my experience, and of course, the first consideration is that we, in the pandemic, we should use what we have and what we know. Of course, with the high flow, if we use very high flow rate, 6 liters per minute of pure oxygen, we can have a very large we can consume much, very high quantity of oxygen. And with NIV maybe could be better. What is your experience with that? What do you think about this, Michela, Jens? Do you have any comment on this issue?
I agree with you, either for what regards patients in the ICU, but also patients on ward. So based also on how the patient is going, and also based on what clinicians are more practical with, I would suggest the same as you say from your experience. So is the pandemic, there's an emergency ongoing, and you have not too much time to titrate and also to keep an eye on the oxygenation of the patient. So probably I would suggest to choose what the clinician is more familiar with.
Jens, one comment about the oxygen consumption.
I think in general, you must admixture more oxygen if you have higher flow rates with a nasal high flow device. This is in general the theory, I think so. But in the clinical practice, I have also looked for an idea. There are some opinions about you can spare some oxygen in some patients. It is not really clear. You have some patients where you must use a lot of oxygen if you use a nasal high flow device, especially in higher flow rate. But in some patients, it is beneficial and support the respiration that you can use a little bit lower oxygen. In my personal clinical practice, I see this very often. There is no rule that you can spare or oxygen or not. But in general, I think the idea could be correct.
I mean,
okay, thank you. And please, Michela.
No, I was just thinking about the fact that maybe because of the stable FiO2 that you can administer with Flow Nasal Oxygen, it could be also an advantage from this point of view. So.
Okay, there is also another question about how to set gas flow with the nasal flow in patients with COVID-19. My personal opinion is that in patients in general with hypoxemic respiratory failure, and COVID-19 is not an exception, I would start always with the highest, 6 liters per minute, and then I would eventually decrease the flow based on patient comfort. What do you think about this?
Yeah, I totally agree.
Yeah.
Jens, for you the same?
I start often with 40 liters per minute to introduce the patients to the therapy, but I go also to 60 liters per minute, of course.
Okay. There is also another question about which comes from social media about the duration of the nasal flow therapy, for how long we can use this therapy And if, particularly in COVID-19 patients, there are risks of a prolonged use of a nasal flow, in the question was mentioned particularly the risk of fibrosis. I do not think that there is any risk of increasing risk of fibrosis with the nasal flow, but there are any risk of coming from a prolonged use of nasal flow. And for how long have you used this device in hypoxemic patients or COVID-19 patients?
For my opinion, there's no problem to use nasal high flow very long. We look after some days to wean patients from nasal high flow before of comfort reasons and the most reasons. And the more patients say to me, no, I want to use nasal high flow once again. And if you can good oxygenate the patients with a low oxygen flow, it's the right time to end the use of a nasal high flow device. On the other way, if you use the ROX index to predict your success of a nasal high flow device, you should use the ROX index to have no delay of the intubation process.
Yeah, I agree.
Thank you, I agree. Please, Michela.
No, don't worry, go for it.
So we agree, that's the point. Personally, I have used also in the past the nasal flow for days, for many days without any risk.
Yes.
So I would say that from this point of view, I do not think that this therapy is able to increase the risk because of prolonged use. There is another question concerning combination therapy. For example, a couple of questions. One is combining, if there can be any benefit combining nasal flow with a simple face mask, the Hudson mask. Not in my opinion, but I would like to have also your advice on this issue.
Yeah, I agree with you.
Jens,
I don't understand the question. To use the nasal high flow with what kind of mask?
With Hudson mask, the simple face mask.
Ah, okay. No,
the simple face mask for conventional oxygen.
I think this makes no sense.
Okay, so we agree on that. While another question is concerning the combination of nasal flow, with NAV in COVID-19 patients. So what I could say is that there is one report in which nasal flow was combined with helmet CPAP, and the combination was able to a little bit combine the advantage of having a high nasal gas flow with the advantage of setting a high level of PEEP, because we know that with nasal flow, the level of pressure PEEP that we can generate is quite modest. If we combine, we can increase the level of PEEP. Do you have any experience or any other comment or data? I would say that I should say that I have never used this combination because it is quite complex for now. And I think that we could probably choose the different technique if we need different effects. So my experience is only based on a single report I know from the literature. Do you have some experience on this, or you have any comment on this? Use of nasal flow combined with other technique?
We so in our ICU in this period of pandemic, what we are doing is that when patients are on CPAP, for instance, and we want to allow them to eat. Sometimes we bridge therapy on Flow Nasal Oxygen. And so usually we used to alternate the techniques. So we go from CPAP to Flow Nasal Oxygen during the feeding period, and then we go back to CPAP. So this is my experience for now.
This is also our experience, but this is different. Than combining the two techniques together. Again, I know that has been described. It could have an advantage, but for now we have no really clinical report saying more than this, more than physiological effects. For now, the technique is so complex, combining the two together, that probably the advantages are not so counterbalanced by the complexity of the technique. There are also questions concerning risk of nasal flow. Few comments were interested in knowing if giving 60 liters per minute may be really protective for the lung. The question was if this is gentle for the lung or it can be associated with some form of trauma, not necessarily in the lung, but also in the airway. Not for what I know, at least has not been described, and from a clinical point of view, I do not have experience in that sense, meaning that I do not believe that there are any physiological reason why 60 liters per minute may be deleterious, and generally, especially for the severely hypoxemic patients, this is quite well tolerated. Michela, Jens, do you have any experience with the risk related to the use of high flow through the nose for the airway and the lung? Okay.
No.
So the question is clearly no. There is also one question about use of nasal flow and silent hypoxia. We know that silent hypoxia is due to the fact that there is a dissociation between hypoxemia that can be also severe, without dyspnea, without a major impairment respiratory mechanics. And we know that, and this is why we have silent hypoxia, and we have dyspnea only when hypoxemia becomes very, very severe, below, let's say, 30 millimeters of mercury. And this is associated generally with an increase in CO2 in the very late phase of acute respiratory failure, hypoxemic respiratory failure. The role of nasal flow for silent hypoxia is just to correct hypoxemia as any other device, oxygenation device. So maybe better, as we have seen, that simple oxygen and least comparable to other non-invasive technique. Your experience in this?
I think also in this situation, it is very important to support the ventilation because of this effect, not only to correct the hypoxemia, to prevent an increase in hypercapnia. This is more beneficial because of the nasal flow compared to standard oxygen.
There is a question that I think is more for you, Jens. Is there a place for nasal flow at home for COPD patients? I think that your presentation has already, at least in part, answered to this question, but would you like to add something else on this question, the role of nasal flow at home in COPD patients?
Yes, in my opinion, it could play a role because we want to correct the hypercapnia in our patient and want to decrease the exacerbation. Both was shown in studies. We have no information about mortality. These informations are lacking. We do it in this way. If the patients have no tolerance of non-invasive ventilation, we try with the same outcome parameters, a trial of nasal high flow. And if you have a benefit, we bring the patient with the nasal high flow at home.
Thank you. There is another question which is concerning the use of non-invasive respiratory techniques in COVID-19 patients or in hypoxemic patients, if I understand correctly the question, is that if nasal flow fails, is it better to intubate directly the patients, or there is room for trying another technique for non-invasive respiratory support? This is a good, very good question, because we are really confronted quite often in this period with this issue. I think that if the patient is strictly monitored and intubation is available, ready available, and if we have experience with non-invasive ventilation, we can do a trial of NAV before intubation. Also trying to understand why nasal flow has failed. A trial meaning 30 minutes, 1 hour, and just take a look at what is going on concerning oxygenation, respiratory effort, intensity of respiratory effort, and dyspnea, and respiratory rate. And otherwise, if we are in less safe context, maybe it could be better to intubate directly the patient. What do you think about this?
Yeah, I agree with you. I think the same. I mean, if you have the opportunity to monitor the patient and the patient is not far from the intensivist, which can actually look at the ROX index or either evaluate some other signs of inspiratory effort, then maybe I would give a trial. Otherwise, go straight to intubation.
I think also the decision must be case-based. Yeah.
Okay, I agree. Is there a role for the ROX index in this context?
Yes.
I would say yes.
Of course. I will remember the ROX index is the ratio of SpO2 to FiO2 divided by the respiratory rates, and it has been validated for intubation, for trying to identify patients who is going to fail with nasal flow, with the value of when this value especially is below 2.85 after the first 2 hours, or a little bit higher after 6 hours. And also it is important to look at the trend, and it has been shown also that a gas flow challenge, the modification of the ROX index with the gas flow challenge may also help in identifying the patients that are higher risk of intubation. There is another question, just 1 second, because I need to read it, concerning the risk there is one question concerning the oxygen toxicity when using 100% pure oxygen, both with nasal flow and with NAV. Of course, there is a risk, but that's the reason why we need also always to balance benefit and risk. And we need to have a target of oxygenation, which is the minimum acceptable. Usually we say between 90 and 96 of saturation, and 55 to 80 PO2. So we need to optimize the oxygen, the FiO2 based on quite modest oxygenation target. And also there is another question concerning the use of nasal flow for weaning from mechanical ventilation in patients with tracheostomy. So do you have any experience with that?
No,
of course I have an experience. We have published data on this, but
there are only a few.
I want to know your.
there are only a few informations about this topic. You have published such a study. Yeah, I think this is a question for you.
Yeah, yes, I would like to have also your opinion. In the study we published, we look at the effect, the physiological effect of high flow delivered through the tracheostomy as compared to standard nasal flow. And what we found is that the physiological effects are modest with the high flow because it's an open circuit. And there are only modest physiological effects present when we apply the highest level of gas flow, 50 liters per minute in our study. In this case, we have a small amount of pressure generated into the airway, small improvement in oxygenation respiratory rate, but these effects are clearly much less important than those seen with the standard nasal flow. However, there is also some importance concerning to the delivery of humidity in the airway. And we have a recent publication in the New England Journal of Medicine in which they have used this technique of high flow delivered through the tracheostomy for optimizing humidity. And they compare intermittent high flow with intermittent closure of the tracheostomy as a way to wean from the tracheo, as compared to continuous application of high flow and counting the number of suction needed as a way to drive weaning. And they found that the continuous application of high flow was better than the intermittent use and a periodic closing of the tracheostomy. So I think that there is a role, not necessarily for the physiological effect, which are different as compared to nasal flow, but also because of improvement in gas conditioning to the trachea. I think that maybe we are late now, but we have room for one last question. Can we use nasal flow in patients who do not cooperate with nasal breathing and keep their mouth open? What is your experience?
I think, yes, if you need not such a high PEEP, you can use nasal high flow in this patient. It's very comfortable, of course. It's the meaning what you want in these patients. If you want to oxygenate, if you want to wash out more CO2, you can use nasal high flow, and it's equal that the mouth is open. It is no problem. It's again, it could be beneficial in some patients. I remember 9 patients with cystic fibrosis have not tolerated non-invasive ventilation and have a very high hypercapnia. We use the nasal high flow on both nostrils, the same what I say in my speech, and then we used it in only one nostril, and the hypercapnia decreased in this patient. It can be beneficial, especially also in this patient. But if you, on the other hand, need a high pressure, like a very obese patient with a sleep apnea, and the sleep apnea is the problem in this patient, you use a pressure in a closed system, in my opinion. That's why I cannot close out that nasal high flow cannot be beneficial in non-cooperative patients.
Michela, anything to add?
No, I'm good, thanks.
I would say that at the end, we could say that we are quite lucky in this period, because different from previous year, we have increased our armamentarium of non-invasive technique of respiratory support. And I think that we should increase our knowledge of this different technique in order to also understanding the physiological effect, in order to choose the right technique for the right patients at the right time. And finally, to deliver personalized respiratory support. With this consideration, I think that we should close. I would like to thank you all of you, all the speakers, my co-chair Michela Roseo, and all of you, the audience of this nice webinar. We hope that you found this interesting, and we like also to thank you, Massimo, for the support they give to the for the realization of this webinar. So I think that we can close, and I thank you again all, and goodbye.
Thank you.
Bye.